welcome our dear friends, professors, colleagues, and fellows all over the world. Today is our 8th webinar through our course, the Bifurcation Campus. Today, we have our dear eminent professors who will moderate this webinar. It is our pleasure to introduce Professor Dr. Adil Azmi, Consultant of Interventional Cardiology at King Fahd Military Medical Complex from Saudi Arabia, and our dear Professor, Professor Dr. Hussein Hishmat, Professor of Cardiology at Cairo University, and our dear Professor Dr. Khalid Al-Tuhami, Consultant of Cardiology at National Heart Institute. We have also today two eminent speakers, our friends Dr. Haytham Sulaiman, Lecturer of Cardiology at Fayoum University, and Dr. Ahmed Saeed, Consultant of Interventional Cardiology at Shbin al-Kom Teaching Hospital. Now I will pass the mic to our dear eminent professors, Dr. Adil Azmi and Professor Dr. Hussein Hishmat, to give us few words before my dear friend Haytham Sulaiman start his case today. Please, Dr. Adil.
Bismillah ar-Rahman ar-Rahim. Dear colleagues, I am so flattered. This is a very special night to me. Flattered, happy, and proud to be among this eminent gathering and forum for this bifurcation campus at the Cardiology Educational Channel. Proud to see this. I've watched a couple of previous episodes from your prestigious channel, and was very happy to see this bouquet of fellows and expert interventionists from Egypt, from different places, both at teaching hospitals, universities, and National Heart Institute, that are not only spreading the knowledge, touching on the guidelines, and sharing the knowledge from the trials, but also presenting everyday practice, including the mishaps, the mistakes that can happen for the younger fellows to correct them. I'm happy to be among my dear friends that I've been long away from, Haytham, Hussein Hishmat, Karim Mahmoud, as well as among my eminent colleagues and peers. Today with my dear friend and younger brother Hussein and my peer Dr. Khalid Al-Tuhami, we will start moderating this session. And I think the first case will be presented by Dr. Haytham Sulaiman. So please, Haytham, you can start.
Thank you, Dr. Adil. It's an honor. We will start on the case. This is a 65-year-old male, diabetic, hypertensive, smoker, and COPD, who was presented at the ER with acute coronary syndrome that turned out to be non-STEMI. Creatinine clearance was 50 milliliter per minute. The echo showed an ejection fraction of 35% with mild mitral regurg and severe hypokinetic anterior wall. He was shocked. Blood pressure was 80/50. That increased to 90/60 using immunosuppressors. So coronary angiogram was decided and done, and the patient was loaded with ticagrelor 180 milligram. This is the first view at the diagnostic catheter. You will see that we have a filamentous vessels, very, very small circumflex, very small but long ramus, two vessels. From this view, we cannot decide which is the LAD and which is the diagonal branch, but they are comparative in size. On the second view, we can see that there is a distal left main disease, an ostial critical LAD, a bifurcation LAD, diagonal branch critical stenosis, an ostial ramus, which is very small in size, and an ostial circumflex branch, which is also very small in size. This is an epicaudal view. And this is the cranial view, showing that the LAD and the diagonal branch are comparative in size. And this is a very long diagonal branch. And as we expected, the right coronary was nearly normal. And that's why this patient was still alive till the diagnostic catheter. This is the vessel supporting the circulation till now. So how would you treat this patient? We calculated the syntax score, syntax 1 and syntax 2 score. We calculated the Euro score, and we consulted the cardiothoracic surgeon while the patient was on table. This is a shocked patient that was kept nearly at 90-60 blood pressure with maximum inopressors. So he must have a solution on table right now and cannot be delayed. So as we are expecting.
If you allow me a question, please, Dr. Haytham.
Please, please.
Can we go a step backwards and know what did the ECG show? Because in non-STEMI, here we're searching for a culprit. So we don't know whether the culprit is the left main, is it the LAD, is it the diagonal?
The ECG showed, I don't have the ECG itself, but the ECG showed diffuse ST segment depression from V1 to V6, 1 and AVL, along with lead 3 and an ST segment elevation in EVR.
So the ECG pushes you towards considering the left main to be the culprit.
Yes, yes. So the syntax 1 score was very high, 39, and the syntax 2 score did not show any significant difference between doing or performing PCI or cabbage for this patient. So we have the two options concerning the syntax 2 score, but of course, according to the guidelines, the syntax 1 score is favoring cabbage over PCI. And as expected, with all these comorbidities, the Euro score, which determines the survival during cabbage or the peri-cabbage survival, was extremely high, 12.82. So this patient is a mortality case to the surgeon. So as we expected, the patient was refused from the surgical team. This is an unstable patient, have two levels of bifurcation, one at the level of the left main and the other one at the level of the LAD diagonal branch. And we have relatively small vessels and we have extreme shortage in equipment. So do anyone have any other suggestions than do whatever we can do to save this patient?
Okay, so I have a suggestion on the shortage of equipment. Let's hypothesize that you are working in the ideal spot and you have all the supplies that you want. So let's try to enlist what are the supplies that you would like to use in this patient, and then we take it from there. Okay. I would start by a mechanical circulatory support by intra-aortic balloon.
Yes. I would like to have a mechanical circulatory support. I would like to have a large caliber guiding catheter, a 7 French guiding catheter. I would like to have non-compliant balloons, small caliber balloons, and hydrophilic wires that can cross easily into the bifurcations. So this is the ideal setup for me to perform this case. And of course, I would have to like an intravascular imaging, preferably IVUS. As we are intervening into the left main. So this is the
Haitham, if
ideal
you allow
set
me.
for me.
Yeah, yeah. Haitham?
Yes, please.
Yes. First of all, I would like to praise that you used the heart team philosophy before taking the decision in such case. This is not just an ad hoc case that you take your own decision and go away or go forward. You made the heart team and you studied the well-known scores for the risk for each option. And then you discussed, as Hussein said, despite the shortage of equipment, you enlisted the proper or the ideal situation. The mechanical support now, let's say the Impella, for example, is not widespread even in the Gulf area. It needs a learning curve, despite it's a simple procedure, but it needs a learning curve and another access wide pore and so on type. Would you consider an intra-aortic balloon despite the questionable results of the shock trial beforehand, before starting your procedure?
Yes, I would use an intra-aortic balloon because the shock trial showed that the routine use of intra-aortic balloon is not beneficial, and will suspect the patient to the complications of introduction of intra-aortic balloon without a significant benefit. This is the routine use. But I think this patient with this ventricle and with the level of blood pressure we've reached using the inotropes and inopressors, I think this patient is a candidate for intra-aortic balloon.
Thank you for this answer.
Trial,
yeah. Thanks for the answer, because I think the key word for failing this trial was the word routine. In each trial, when they tried to push a routine use of any device, like the intra-aortic balloon in the shock trial or the export catheter in the TASTE or TOTAL trials, the result was not encouraging at all. It's individualized decision in each and every case that you should select which weapon of your armamentarium that will help you during the procedure. So that's the right answer. Routine is wrong, but individualized use, that's the correct one. So go on, please.
Thank you. So we've planned for a bifurcation PCI to the diagonal LAD using a mini crush technique, and a PCI to the distal LAD because we have an extension of disease after the diagonal branch, and PCI to the left main LAD. The circumflex was very small in caliber, non-dominant, and we did not plan to do anything to the circumflex except as a bailout. So we used two PT2LS wires, a 2.0 by 20 millimeter balloon for pre-dilation. We plan to implant a 2.5 by 29 millimeter stent at the diagonal, a 2.75 by 29 millimeter stent at the distal LAD, and 3 by 29 millimeter stent at the extension of the left main LAD. So this is the pre-dilation of the diagonal branch. And the pre-dilation of the ostium of the diagonal branch. And this is the first stent at the, or protruding minimally at the ostium of the diagonal branch. Here is the first obstacle that I faced. This guiding was a very, very old-fashioned guiding. We didn't have any other guiding than this, with an internal diameter of 0.68 millimeter. It do not accommodate a stent and a balloon. So this is an extreme risk, and I admit that this is an extreme risk to have a protruding stent into the LAD without an opposing balloon to crush it in order to deliver, to be able to deliver anything into the distal LAD. But this was the only equipment that I have. And this is the first obstacle and first crisis that I've met. That I know that I am protruding into the LAD with the diagonal stent without an opposing balloon. So I've deployed the diagonal stent. Then I've pulled out everything from the diagonal after I've managed to deliver a balloon at the wire of the LAD to crush the diagonal stent. It was with extreme difficulty, but unfortunately, I've succeeded to pass the balloon, and I've crushed the lesion, the stent of the diagonal branch. And this is the picture. The diagonal branch is now open with a very good caliber. And we have two lesions, one distal to the diagonal and one which is the main issue, which is the left main proximal LAD. So I delivered the first stent, which was a 2.75 by 29 millimeter drug-eluting stent, distal to the diagonal. And these stents, the knob or the marker of the balloon is not included into the stent length. So this is where my stent begins in order to have a space for overlap, which is not opposite the diagonal branch.
Haitham, this is very important point to illustrate. When you plan an overlapping stent covering a long lesion, try to make the overlap away from a sizable side branch. So this is nice of you to illustrate that your stent here is inside the knob. It's not at the knob. Otherwise, that space will not exist.
Thank you, sir. And using the same balloon, I've confirmed the length of the left main LAD stent. And now this is the 3.0 by 29 millimeter drug-eluting stent into the distal left main proximal LAD overlapping with the distal LAD stent. And this is the deployment. And now we are facing another problem. We do not have any non-compliant balloons to do post-dilation or to do the final kissing of the bifurcation, or even to expand the 3.0 stent into the left main properly, because the 3.0 stent will never reach more than 3.5 millimeter in diameter at the left main. So, and this will be an under deployment of the stent at the distal left main. So I improvised the equation of doing a combination between the 2.75 and 2.5 semi-compliant balloons of the stents inside the left main, and I've calculated it, and the final diameter will be at the distal left main 4.0, which is the best I can figure out at this situation. Mind you that even introducing two balloons inside this guiding was extremely difficult. This was a very small internal diameter 6 French guiding that gave us a hell while passing our equipment. So I've managed to introduce the same balloon of the diagonal stent into the diagonal stent another time, the 2.5 by 29 millimeter balloon. And I've dilated the diagonal. Then I've did the first kiss, introducing the balloon, the 2.75 balloon and the 2.5 balloon. Then I've did another kiss, and this is the final result. Fortunately enough, the filamentous circumflex and ramus branches are the same. They have the same severe disease, but they have the TIMI3 flow, and the patient began to build up his blood pressure after the final case and after restoration of the flow into the left main LAD and diagonal branch. And this is the last angiogram. So any comments?
Hussein, would you like to start?
Yes.
But be gentle, please.
هيثم. Hi هيثم.
دكتور خالد ازي حضرتك؟
الحمد لله. How are you? Fine. But
Fine, thank
it
you.
is very. Thank you. Yeah, we all learning for these complicated cases, and I think it is give us more experience than simple cases, especially for shock patient.
Yes.
But I think you make it hard for you. Like you start by diag. Yani if you can see, you can start by LED and then evaluate if the patient is okay. You can operate later for diag, or see you make it because you have shortage of material.
This is a very, very important question,
small
sir.
caliber guide not allowing to you. So I prefer you make it easy for yourself. Fix LED, and then patient is okay. You can postpone it to get more. Yeah, you have more equipped to deal with the patient. If not approved, you can do to go to the egg.
Two things that made me decide to do the diagonal as a two-stent technique from the start. The first one is the caliber of the diagonal branch and its extent. This is a nearly a second LAD that extends to a very large area of the myocardium. This is one thing. The other thing, that the angle and the extent of the disease at the ostium and proximal part of the diagonal branch would make it very hard to do it as bailout or tap technique, one stent technique from the start. So I adopted the hard way to do it as two stent technique from the start because of these two conditions.
Okay, excellent work for you. No comment. I think an excellent result for the patient.
Thank you so much.
Haytham.
Dr. Hussein?
Yes, I agree with the two-stent strategy because the diagonal is not just a big size, it's a lengthy, it's a long vessel, which means that it supplies a sizable territory, and it has disease extending more than 5 millimeters from the ostium, and it's an acute coronary syndrome, so there is a chance that you have a snowplow effect with the plaque or carina shifting more than in chronic situations. So I agree to this two-stent strategy. When you're doing a two-stent strategy with a 6 millimeter, then you'd better try to do stepping of the crushing. So you deploy the stent, you take everything out, and you just keep a 2 millimeter balloon so that you do the crushing with the 2 millimeter balloon. Then when you have all the equipment out, then you can crush with a 3 or even a 4 millimeter balloon. Stepping of the crushing when you have a small guiding catheter.
Okay.
For the left main, my worry here is that the pot is not perfect. You can do a pot with a semi-compliant balloon as well as a non-compliant balloon. Both can do the job.
Okay.
What I would prefer is if you have the luxury to bring the patient back in a few weeks, in a few months when you are more equipped, just for optimizing the left main, so that he doesn't come again next time with a miserable shock and an under-expanded stent. Would be difficult to treat. These are my comments.
Thank you so much, sir. Actually, this was what happened. 1 month later, I've deployed a 4.5 millimeter non-compliant balloon into this left main, and surprisingly, it accommodated it very well. So I've brought the patient again with a proper equipment. Dr. Adil?
Yes, first I agree with the two-stent strategy from the start. As Hussein said, this is a sizable and long diagonal that cannot be dispensed with in a shocked patient. And if any mishap happens during stenting the LAD, we will be in much more trouble. Second, the only excuse of deviating so much from the classic work here is, as you said, the lack of equipment. And you have a dying patient, shocked patient. So thank God you needed a lot of luck and praise from God that Alhamdulillah was there and the patient went off the procedure. But at the end, we saved the life. And as you said, optimization later on was mandatory to avoid later on under deployment or malapposition of the proximal left main stent that can invite future problems. So thanks for the courageous attitude and well done.
Thank you so much, sir. Thank you so much.
So Haitham, I just have one, 2 points.
Please.
Was it available to use another femoral puncture from the other side and use another guiding catheter that can accommodate the balloon that can crush the previous LAD stent? It's just an idea to use.
Yes, I've got this idea, but if you look to the left main ostium,
Yes.
I was afraid to do another complication at the left main ostium by introducing two stiff guidings. This guiding is extremely stiff that can do a problem in the of the left main. So I've had this idea. It's a brilliant idea, but I was afraid to do anything to the left main while exchanging two guidings opposing together into a left main that is relatively or angiographically maximum 4 millimeters in diameter.
Yes, this is my second point. To cover the ostium of that left main, if I choose to stent the left main LAD, I think I would have covered the ostium of the left main with the stent.
Again,
it looks diseased from the beginning, the ostium, because this is not the caliber of the usual left main. So I think the atherosclerosis is diffuse. So it is involving the ostium of the left main. So I think I would use a longer stent, like a 38 millimeter, so I can cover the ostium of the left main overlapping the LAD stent.
Again, the limiting factor here is the equipment. If I've covered the ostium of the left main, it's mandatory to have a 4.0 non-compliant balloon to flare up this ostium of the left main. Otherwise, it will accelerate the atherosclerosis and the complications will be tremendous. So again, the lack of equipment didn't encourage me to go to the ostium of the left main, because I will not be able to flare this stent properly. And I do not have the courage to have two semi-compliant balloons flaring the ostium of the left main, to tell you the truth.
Well done.
Haitham, may I add a small comment, please?
Yes, you may.
Actually, what Ahmed Saeed mentioned now is a very good choice you may have. You know, in left main trifurcation, we use what's called ping pong technique. The idea behind using two guiding casters, you will just use each guiding caster with one wire. In such a case, you deal with and only one guiding will be cannulated to the left main, and the other one will be disengaged. So you can use stent and a balloon, or if you deal with the trifurcation, I may show it next week, inshallah, in the webinar of left main trifurcation, when I need to do 3 balloon inflation at a time.
I know, Abdurrahman, the only concern here is that we have very short equipment, and I was fearing from doing anything into the left main ostium while exchanging. I know that one guiding will be cannulating the left main, and the other one will be at the aorta, but at the exchange, you have a possibility that this guiding might migrate into the ostium of the left main, which is, to my opinion, is not healthy. So this was my fear of doing a double guiding catheters or the ping pong technique. This was the only concern for me to do it.
You do a nice job.
Thank you so much. So I think we will go to the case of my dear friend Dr. Ahmed Saeed.
Yeah, yes, I think. Thank you.
Okay. Any other comments from the professors? Dr. Khalid, Dr. Hussein, Dr. Adel?
No comments from my side.
Okay,
I think
thank
you
so
said
much.
them, which is fair enough.
No comments. That's fine.
Thank you so much.
Okay, thank you, Haitham, for this wonderful case, and you deal with it with great courage, as Professor Dr. Adel said. Now, it is my pleasure to introduce my dear friend, Dr. Ahmed Saeed, and also welcome Professor Dr. Khalid Touhami, who will moderate this case with Professors Dr. Adil Azmi and Professor Dr. Hussein. My dear friend Ahmed Saeed is a very good interventionist and will present a case now with complications mean. Ahmed, please.
Yeah, thank you, Dr. Abdurrahman. It's an honor to be with our professors, our role models and mentors. So my case today is a 65 years old lady. She is diabetic hypertensive and she was non-STEMI, and her ejection, it was like global hypokinesia, and the ejection fraction was 30 to 35%. That was her coronary angio. So here we have, this is the caudal view. We have here an ostial left circumflex, significant disease. We have also a proximal LED lesion at a bifurcation with a diagonal branch. Actually, it was done by one of my colleagues. So he decided to, and this is the LED, it is a significant lesion 110 in Medina classification of the LED. And this is the right coronary artery, seems free of significant lesions. So he started wiring the LED first, and then the diagonal, and then he went for provisional stenting to the LED. And that was the deployment of the LED stent. Actually, with this inflation of the stent, the patient went severe hypotension and severe bradycardia that was near to cardiac arrest. So recovered with atropine and started here on vasopressors. So that was the angio. After that, here we see some slow flow We thought it is due to the hypotension. The diagonal is preserved, so the patient recovered after that. And here, my colleague decided to go for the ostium of the left circumflex. Now the patient recovered. We see that the bradycardia improved, and here the TIMI flow is almost TIMI 3 flow. So he went, has withdrawn the wire of the diagonal branch and then put it inside the left circumflex. And he decided to do a flush ostial stenting of the circumflex, as he did here. So from the beginning, we notice some disease in the ostium of the LAD that is not significant. So he stented the ostium of the left circumflex and post-dilated with the same balloon. At this time, the patient again went to the same bradycardia and severe chest pain. And that was the image. After that, the patient was actually severely distressed at this picture. Here we notice some haziness at the ostium of the LAD. That is most probably by plug shift from the ostium of the left circumflex. So at that time, he asked for our help. So hardly we could push a balloon inside the LAD ostium to crush the stent that was protruding inside the left main LAD. And then after that, we could crush the stent with this balloon. Even with this inflation, the patient went into cardiac arrest, just deflated immediately. And then again, resuscitation with a cycle of CPR, and the patient recovered. So we recrossed to the circumflex, and we opened the stent struts of the left circumflex. And again, the patient arrested and resuscitated for one cycle. At this time, we have decided to put the left main LAD stent. We notice here from this view that there is some disease in the ostium of the left main. So we decided to cover the ostium of the left main with the stent. And that was the deployment of the left main LAD stent. At this level, again, the patient went to cardiac arrest. With each inflation we do inside the LAD or the left main, the patient goes to bradycardia and cardiac arrest and resuscitated for one cycle again, and she recovered. Even with this put, the patient goes to cardiac arrest. So at that time, the patient status really recovered from the hemodynamics, but here we need the final kissing balloon, and then the pot after that. Actually, regarding the critical status of the patient, the decision was to leave the patient at this stage alive with this TIMI 3 flow, and he is alive. She is alive right now. So the decision was not to do a kissing balloon, a final kissing balloon, and just to continue for a follow-up and leave her for stabilizing her hemodynamics, then to decide if she developed symptoms again, then we can go for a second look angio and see her. This is the end of.
Can I interrupt you, Ahmed?
Yes, please. I just finished the case.
Okay. So at the last shot or last injection, I don't know if this is an end-on artery or there is a haziness at the distal edge of the stent of the LAD.
Which one you mean, Hassan?
This at this picture.
Yes.
At the distal LAD after the bend, there is some haziness.
You mean here?
This is an end-on. Yes,
No,
here.
it is just an.
This is an
I think it is
end-on.
an overlap because here we have the
Okay.
cranial. Look at this view. Here, it's the vessel is already diseased, so it's not haziness of thrombosis. I think it's. You mean this area? It's a plaque, but it's not a significant plaque.
So it was an overlap between the LAD and this is and this tiny septal perforator.
Yes.
Okay, thank you.
So, dear professors, Dr. Hussein, Dr. Adel.
Yes, thank you, Dr. Ahmed, and this case highlights many aspects of practicing in the cath lab. So, if you allow me a few minutes to give some comments,
Yes,
I would
please.
start by the decision making. I mean, when you do an angiography and you find a focal lesion, bifurcation lesion in the LAD and an ostial circumflex, it's unlikely that these lesions would result in global hypokinesis and severe LV dysfunction. So, what was the ECG showing? What was the culprit from the ECG? What was the troponin? These things need to be clear before we put the patient on table. So that's the first point. The second point is in the cath lab setup. I see the images are crystal clear, which means the cath lab machine is very nice. But what really worried me is that once you deploy a stent without pre-dilatation, and you find significant nori flow, and you find a starting thrombus formation inside the stent or proximal to the stent, then the first thing that I would recommend to do is checking the ACT. Was the patient loaded with clopidogrel? Was it the brand clopidogrel or ticagrelor or a generic clopidogrel? What was the ACT? Do we have an ACT in the lab or not? And we need to make sure that the ACT here is somewhere above 300. Another issue is when you put stents and things are not going well, then think that something else needs to be done apart from putting a stent. And the stent here in the ostium of the circumflex to me seemed a bit out of focus, because ostial circumflex lesions, in the majority of cases, they are stable. They usually don't result in cardiogenic shock, and they can be very well managed medically with a drug-coated balloon, or even if you try to tackle it, then you have to take it all the way from the left main into the circumflex, treating the LAD provisionally, and then going from the stent of the left main into the LAD. So I'm glad that the patient could survive all these troubleshootings along the way. And I hope that this would give us lessons for the future in decision-making, in cath lab setup, and in choosing the proper bifurcation technique.
Yes, thank you. Actually, there was no ACT machine to measure the ACT in the cath lab. The patient was loaded with the ticagrelor, the brand, yes, not clopidogrel. I think it was not a thrombosis inside the stent. The previous LAD stent, there was a TIMI2 flow after that. I think it could be maybe he went into high pressure during the stenting and post dilatation, and usually we face this with high pressure post dilatation. But actually, even with each balloon inflation, the patient goes to significant bradycardia and hemodynamic compromise. I think it could be due to the impaired LV ejection fraction or the impaired LV systolic function. Here, the ostium of the left circumflex did not. It was not the cause, but here I think there was some haziness in the ostium of the LAD that made the patient goes to significant chest pain and the hemodynamic compromise after stenting the ostium of the left circumflex. Here at this point, that's why we went immediately and crushed the stent, and then after that the patient significantly improved, so we could continue the procedure after that. But even with each time we inflate inside the left main or the LAD, the patient goes to significant hemodynamic compromise. Actually, we didn't have a hemodynamic support. That's why I think this LAD is a precious vessel for this lady.
Okay, Dr. Adil, do you have any comments?
Yes,
would like to hear your comments on the case.
Very nice illustrative case that has some points to be worth mentioning. If we notice the diagnostic from the start and taking into consideration, as Ahmed said, the global hypokinesis of the patient, we might think that this left main is not healthy at all. This left main is diseased from the start. And the plaque in the circumflex, the utmost burden was in the ostium of the circ, but this plaque has an extension, a sizable or considerable extension inside the left main. And here comes the problem of doing what we call the flush stenting. Despite this angle seems favorable, but it seems also more safe if you deploy such a stent to prolapse or to extend into the left main. This will make your life easy if anything happens with the plaque shift or carina shift to rewire, rather than to prolapse only one or two struts. And this will give you a hard time, like what happened here during the crushing of the stent. So my strategy would be different in deploying the circ stent. I would place a long stent extending directly into the left main, and maybe I would have done this earlier than intervening the LAD. After securing the left main and the ostium of the circ, then I would go dilate this strut in the LAD, and then I will push my gear inside the LAD and correct it afterwards as a second step. That's my
so Dr. Adil, you prefer to do a cool-out technique into this bifurcation rather than do a mini crush or a crushed stent into the ostium of the circumflex?
Yes.
Okay.
So I guess we don't have any further comments for the time being from our dear professors moderating this session.
I have one more case, Zahran, if time can allow.
Yes, we have time.
Yes, it is a disaster also that we have been called for.
We learn not to do, and we learn what to do also. So we will be glad if you can present your next case, and I would like to invite Professor Adil Azmi to moderate with you step by step, and then I want Professor Hussein Hishmat and Professor Khalid Tuhemi, if they are also with us, to tell us the learning points from the second case. So please start sharing your case.
This is the second case. Sorry, it's moving autoplay. So actually, this is a lady with an ostial. This is a man with an ostial tight LED and a mid-segment significant LED. One of our colleagues went to stent this mid LED, and then he decided to go for Zabo technique for the isolated ostial LED. So he did the stenting of the mid to distal LED. That was stenting to the mid segment, and then he post-dilated. It was reasonable. And then he decided to go for Zabo technique for the ostial LED. That was the situation here. So he has put one wire inside that ramus and wire inside the LED, and he went for the stent over the two wires with the distal strut just at the ramus wire, and without any preparation of the lesion, he decided to direct stent the ostium of the LED, and that was the stent going inside. He tried to advance, it was not going. So he just withdrawn it inside the guiding catheter, and then he tried to push again. It was not going, and then that happened. He has withdrawn the stent, and then the balloon came out, and the stent slipped inside the left main, and it was hanging on the calcified ostium of the LED. And that was the it's again, this is the same view, trying to push and then pull out, and the stent kept slipped inside the left main, hanging just at the ostium. And fortunately, it was a 4.0 millimeter stent. So at that time, he called us for help. So we have tried with the small balloons to go inside. We kept the wires in place, and then we tried to go with a small balloon inside the stent, trying to retrieve it or deploy it. We couldn't pass even with we tried with a 2.0 balloon that could just go inside the proximal of the stent, pushing this. That was the smallest one. Yeah, so here we could push as much as we can. Still, the stent didn't cross the ostium of the LED. At this time, we have withdrawn the wire of the ramus because it was just below the struts of that LED stent. We didn't left main slip the stent, so we didn't complicate things. We have withdrawn the wire and kept the wire inside the LED and tried to go even with a small balloons. Actually, the patient was stable, hemodynamically stable. So that was the maximum we could advance the balloon inside the stent. We didn't have a snare at that time. So here we decided to go and inflate at half of the stent, so we can just stabilize the placement at the distal left main. So here we inflated with this balloon, so we can open a track to pass another balloon inside. And here it was also, we could pass this level. We could pass a balloon just here inside the ostium. So we have dilated the LED ostium, and then the ostium just distal of the left main. So here the stent, we have the stent deployed inside the left main and missing the LED ostium. So we decided, this is after deploying the left main stent. We have athymic flow inside all the stent. At this level, we wire the ramus again, and then overlap the left main stent with another stent just to cover the LED ostium first. so we can secure the main vessel of the patient. That was the deployment of the LED stent. And then we recrossed to the ramus and we did a kissing balloon. And that was the result after doing the kissing balloon. At that time, we didn't want to complicate things and insert another stent, because already if we put a stent inside that ramus, we can compromise that circ and this big OM. And my idea was to just go safe now with this patient and then to bring him again and then to complete the procedure with this OM branch if he is symptomatic or having significant ischemia. If he's not having, so to continue on medical treatment. And that was the final result. So, dear professors, what do you think, Dr. Adel, Dr. Hussein?
Yes, Ahmed, it's a very nice rescue operation, as a matter of fact, but let's revise it from the start. In a critical situation, in a critical position like this trifurcation, I don't know the idea about direct stenting. These lesions should be well prepared. This will give you the chance of feeling the lesion and well sizing your future stent as well. But pushing just a stent blindly and then pushing it with force again, I think this is a mistake that we should never repeat again. Prepare your lesion, test it with a non-compliant balloon, and if it doesn't go, then test grading inflation. And only when you feel that it's safe to deploy your stent, go with it. Otherwise, never do that again. You have done, as I said, a good rescue operation. You played it safe. You played it with minimal risk. And even you left this OM, which I fully agree to be left at this stage, even for medical treatment in the future, because it's non-prognostic at all. It may end up with some angina that can be treated medically, or even with a small infarction that's not important at all. But you have saved the life-threatening position or region of the patient with what you did. So I appraise really what you have done. That's my comment.
Thank you, Dr. Adel. Dr. Hussein?
Yes, again, like Dr. Adel said, I know the practice of trying to economize material by avoid using a pre-dilatation balloon by going for direct stent. But the lesson here is that when you try to economize by omitting an essential step, it ends up by the need to do a million more steps that could have been saved by just one essential step, which is here is pre-dilatation. The second issue was the Zabo. For the left main, if you're planning to stent the ostium of the LAD, we know that you have to stay well into the left main, not essentially the ostium, but well into the left main. Because if you try to place just one or two cells and with the help of a wire, I don't know what they do, you will definitely miss the plaque. And you're just starting to invite more and more problems. So the biggest lesson here is when you're stenting the ostium of the LAD, you either take it from the left main well into the left main, or you're referring for Lima to the LAD. The issue of losing a stent in the left main, you have to see it in your lifetime. If you are lucky to get the wire, if you still have the wire inside, then you try to deploy it wherever you can, if the size is proper. If you don't have the wire inside, then you try to snare it. And if the lab is not equipped with a snare, as I expect, then you try to do your own snare by just trying to cross with any two wires, and you keep torquing them, torquing them, torquing them, torquing them, until they twist over themselves. And then you can use them to pull the stent out if we don't have the classic snare. Again, a nice save, and we're all glad that our patients are saved, and we learn from mistakes. That's how we progress.
We have any comment from Dr. Khalid Al-Tuhani?
No, I think Ahmed did a good job. And I said before by other professors, Dr. Ahmed Ad, Dr. Hishmat, for this patient, especially in distal left main and left main, there is no, I think no rule for direct stenting. I think IVAS must be needed. So I think for this patient, I think if the IVAS is used, it is better for this patient. This is my opinion. But I think Dr. Ahmed did a very good job. He rescued the patient, and this is the most important patient. Our patients are safe. And thank you, Dr. Ahmed.
Thank you, Dr. Khalid. Thank you so much.
Thank you, Dr. Khalid. So I will pass the mic to Professor Adel Azmi to generously wrap up the three cases for us regarding this session. So Professor Adel, can you give us a wrap up, please?
Thank you very much, Dr. Zahran. I think we had three educative cases tonight. The first case illustrates how a good improviser can act despite the lack of equipment. He's only excused, as I said before, because he's saving a life of the patient. He deployed a hard team, and he used what he had in hand, deviating a little bit from the classic, but at the end he managed to rescue the life of the patient. And I like what Haitham said, that he brought the patient once again for optimizing what he has done on this hot night by both dilating and optimizing the deployment or the position of the left main stenting. The second case presented by Ahmed was also a good example of how to deal with a hot situation, illustrating some points to be considered. The good position of the stent, and as Hussein said, taking all together the clinical situation. Global hypokinesia is not a function of a focal or a mid-segment LAD lesion. So I think we should discuss and consider beforehand our policy of tackling a left main disease or a seemingly osteal plaque in the circuit that is really extending into the left main, and put this into consideration before dealing with a mid-segment LAD. Second, again, stressing the importance of taking care of this flush technique, that it's better and safe if you consider continuation inside the left main to cover it, so as to recross easier afterwards. The third case also illustrates good lessons. As Hussein said, never save an essential step. Good preparation of the plaque is very important, especially in a critical region like this trifurcation. And if you fail to pass your stent in the first time, never try it again, never try to push or daughter, as we say again. This is a very critical that will invite future problems that will be very difficult to correct ideally. I would say Ahmed did a great job for rescuing the patient, but we all confess that this was not the ideal that we planned beforehand, but he managed it partially well, and then he can correct it later on when the situation is a little stable and the patient is more stable. So really that was educative session with lots of lessons to be learned, some to be stressed and some others not to be attempted in the future for our fellows. Thank you very much.
Professor Adil. I would like to grasp the opportunity of having Professor Hussein with us because Professor Hussein worked in several national and international cath labs in Egypt, in Cairo, in Germany, in United Arab Emirates also. So I would like to take a couple of words from Professor Hussein Heshmat regarding his advice to interventional cardiologists at the middle age. They are still let's say, not so warming up in their phases of education regarding bifurcation lesions, because sometimes also lots of complications happen from taking stuff outside what's orthodox to be known as fixed steps in performing what we learn. So, Professor Hussein Heshmat, would you give some words as an advice regarding preparing yourself for bifurcation, like the type of equipment that you consider as basics to have in the cath lab before you jump to doing an elective bifurcation, because sometimes the bifurcations come in emergency situations. So if you are going to do an elective bifurcations, so what would you advise us to have in our toolbox, Professor Hussein, please?
Okay, thank you, Dr. Ahmed. My messages would be more of behavioral rather than technical. So the big issues that I see is we need to study the patients before they are on table. We need to know the history properly, the patient should be examined properly, the ECG, we need to know it, the echo findings, the serum creatinine. You need to understand the patient before you put him on table. How frail is he? Which lesion do you expect to be the culprit? So study the patient before the patient is on table. It saves lives. That's number one. Number two, as I said, try not to cut it short. When you try to omit essential steps because you need to save the patient's budget, because you think you need to shorten the procedure time, it usually ends up in more time and more resources being exhausted and more money being spent. And this particularly applies to the issue of direct stenting, omitting the balloons, the issue of imaging. I know imaging is expensive, but in some cases it's essential. So these are the two behavioral pieces of advice. Now, as regarding the technique, what do you need to have if you are indulging in complex PCI in general? The biggest issue I see is, as Haytham said, the small guides. We love to do 6 French so that the compression is easy, and they are the ones which are readily available. But I would hesitate to go into a real serious bifurcation left main with the 6 French. Be very liberal in escalating to 7 French and even 8 French. It's not shameful at all, and it really saves your neck in some difficult situations. So the first issue is the big guides. The second issue is the wires. If you're trying to do a classic DK crush, it means that you will have to do a recross more than once. First across a crushed stent, then through a main stent, and then a crushed stent. So you need to be equipped with the wires. At least familiarize yourself with 3 wires, maximum 4 wires, so that you can navigate them safely, and try to familiarize yourself with double curves. This is a concept that we are not very familiar with, but again, it saves your life. It saves the patient's life in many situations. The other thing that I see it's becoming more and more useful is the reverse curve. Is that you create, when you have a difficult angulation, a very difficult diagonal which is retroflexed, or circumflex that's retroflexed. Here you need to, if you have the luxury of a curved microcatheter, like the Venture of the old days, and now there's, I forgot the name, it's one of the turnpikes that has a 40-degree angle for
the super cross.
Yes, the super cross. And there is another one also, it's from Teleflex, I forgot the name. So you either use this for retroflexed side branches, or you use the reverse wiring through a dual lumen catheter. So these are the technical issues, but to me, they are not as important as the two conceptual issues, which are studying the patient properly before putting him on table, and trying not to omit the essential steps, because it usually fires back worse.
Thank you so much, Professor Hussein Hishmat, for giving us this advice. And thank you so much, Professor Adel Azmi, for giving us this advice. Professor Adel is performing all kinds of interventions in Kingdom of Saudi Arabia currently, previously also in Germany, Cairo University. Professor Hussein Hishman currently also in United Arab Emirates, previously also in Germany and Cairo University. Professor Khalid Touhani, also one of the most experienced operators in the National Heart Institute, and we learn a lot from his advice. Professor Khalid, would you like to add something before we finalize the session?
I think Professor Dr. Heshmat and Professor Adil summarized, but I like to add 2 points, two essential. When you go to bifurcation lesion, you must, before starting, you must have a plan what your procedure. That's you are doing tap or double kiss crash. So you are planning what you are doing. What's the planning you are doing? This make it easier for yourself, and you have to learn at least two techniques, whatever two techniques, and you do it well. You don't have to learn all the techniques, but you don't do it well. So I think if you know two techniques very well and you trained very well, I think you get good result. That's the most two issue. Make it easy for yourself. You have only two techniques at least. You have to know it very well for you. And before starting, you must have a plan for what procedure for that bifurcation lesion. The side branch, the side of the side branch, the angle of side branch. That's the most important things I think for for good. You have good results, successful result for bifurcation lesion. And thank you all for making me share this very nourishment knowledge for me. I learned too much for this because we learn it from our pitfall for other, and everyone has a pitfall, and that's why we're learning for our mistakes for better result. And thank you again.
Well, thanks a lot, our dear professors. Again, Professor Adel Azmi, Professor Hussein Hishmat, Professor Khalid Touhani, for joining us tonight. Usually, the complication session needs a very brave presenter to show the work that has been done, because we usually have hundreds of cases where we did the job wonderfully, and we have a very few cases where the situation was a little bit showing us hard times. It takes a lot of courage to show our mistakes to everyone, so people can learn actually by sharing this experience. It wouldn't have been completed without the presence of our elegant moderators tonight. So thank you all. Next Tuesday will be the final session involving trifurcations and quadrifurcations for this bifurcation campus. And next Saturday, we will complete with our congenital heart disease course. It will be discussing the second part of the webinar about the single ventricle. And next Thursday, we will have a very interesting webinar with international speakers about the very operative evaluation for the TAVR procedure regarding the imaging, the echo and the CT with Dr. Uzge from Turkey. And we will see some cases presented by Dr. Abdeladir from United States of America. So stay tuned for this session. I would like to thank the whole CEC board for their contributions tonight, and I would like to thank the moderators for allowing us to share with them their great experience. Thank you again and see you all. Bye-bye.